Paolo needs to focus.
Yes. Hi, my name is Louise Niklasson, and I'm a 5th year medical student at the Karolinska Institutet. And the title of the project is Electrocardiographic Left Ventricular Electrical Remodeling, Incremental Prognostic Value and Relation to Cardiovascular Magnetic Resonance Measures of Function and Tissue Characterization. And I will start with the background. And cardiovascular diseases are a leading cause of morbidity and mortality worldwide. And several risk factors for unwanted cardiovascular events have been identified. And this include left ventricular hypertrophy, myocardial electrical remodeling, myocardial fibrosis, and reduced ejection fraction. And all these conditions have shown to be related to adverse cardiovascular outcomes. And first we have left ventricular hypertrophy, which is defined as the anatomical increase of the size of the cardiomyocytes of the left ventricle. And this condition can be detected by imaging methods, including cardiovascular magnetic resonance and echocardiography, but it can also be detected by electrocardiogram. Then we have left ventricular electrical remodeling, which is defined as pathological changes in the electrical conduction characteristics of the left ventricle. And this condition has historically been described as left ventricular hypertrophy by ECG. And the only way to detect this condition is by ECG. Yes, and it's known that the conventional 12-lead ECG has limitations in diagnosing heart disease. However, over the past few decades, multiple advanced ECG techniques have been implemented, which has led to the improvement of the diagnostic use of the conventional ECG. And these advanced ECG techniques include electrocardiography and singular value decomposition, amongst others. And yes, and these advanced ECG techniques can be used to determine the advanced electrocardiographic left ventricular systolic function score. And this is a multi-parameter score that expresses the likelihood of left ventricular systolic function ranging from 0 to 1. And it has a high validated sensitivity and specificity for identifying left ventricular systolic function, which is defined as having a left ventricular ejection fraction lower than 50%. And the score consists of 5 components, which are the spatial mean QRS-T angle, the Z-lead QRS voltage, the total 12-lead QRS voltage, the single value decomposition based T-wave dipolar voltage, and the singular value decomposition based QRS wave non-dipolar voltage. And this score reflects the degree of left ventricular electrical remodeling. Moving on to extracellular volume fraction, which is defined as the proportion of the myocardium that consists of extracellular space. And this can be used to measure fibrosis, amyloidosis, infarction, or edema. And it can be detected by cardiovascular magnetic resonance. So, in summary, it's known that high left ventricular mass index, high extracellular volume fraction, and low ejection fraction detected by cardiovascular magnetic resonance, as well as left ventricular electrical remodeling by ECG, all predict poor prognosis. However, the prognostic value of these measures have never been studied head-to-head, and furthermore, the impact of the cardiovascular magnetic resonance measures upon ECG criteria for left ventricular electrical remodeling is not known. So, therefore, the aims of our study were to evaluate the relative contribution of left ventricular mass index, extracellular volume fraction, ejection fraction, and left ventricular electrical remodeling to morbidity in heart failure and all-cause mortality, and to investigate the impact of the cardiovascular magnetic resonance measurements of left ventricular mass, extracellular volume fraction, and ejection fraction upon ECG criteria for left ventricular electrical remodeling. And now we have reached the methods. And the study design was a retrospective observational cohort study. And the patient population consisted of patients that had undergone a cardiovascular magnetic resonance examination between 2010 and 2015 at the University of Pittsburgh Medical Center in Pennsylvania in the US. And this is a figure that demonstrates the patient selection process. And as you can see by looking in the top box, 1,704 patients underwent a cardiovascular magnetic resonance examination between 2010 and 2015 at the University of Pittsburgh and met our inclusion criteria of being of or above the age of 18 and having measurements of left ventricular mass, extracellular volume fraction, and ejection fraction. And out of these patients, 470 met one or more of our first set of exclusion criteria, which were previous myocardial infarction, previous revascularization, non-ischemic or ischemic myocardial scar on cardiovascular magnetic resonance, left ventricular end-diastolic volume index above 120 grams per square meter, hypertrophic or dilated cardiomyopathy, amyloidosis, prior cardiac surgery, severe valvular heart disease, significant coronary artery stenosis determined by invasive coronary angiography or treatment with digitalis. And after this first exclusion, 1,234 patients remained, and they went through a second screening and exclusion based on their ECG findings, and 762 patients got excluded in this second exclusion. And the exclusion criteria were sinus rhythm of or above 100 beats per minute, ECG not acquired within 30 days of CMR, cardiovascular magnetic resonance, that is, paced rhythm, atrial fibrillation or flutter, abundant premature atrial or ventricular beats, QRS duration above 120 milliseconds, left anterior or posterior fascicular block, left or right bundle branch block, and indiscernible P waves. And after including and excluding patients, we had a final study population of 472 patients. And this represents 28% of all the patients that underwent a cardiovascular magnetic resonance examination between 2010 and 2015 at the University of Pittsburgh Medical Center. And these patients' morbidity of hospitalization for heart failure and all-cause death were compared with regards to their cardiovascular magnetic resonance findings and their ECG findings. And the cardiovascular magnetic resonance imaging and analysis were done with a 1.5 Tesla MRI scanner, and left ventricular mass, extracellular volume fraction, and ejection fraction were measured using standard methods. And the ECG acquisition and analysis was done in two steps. First, we retrieved digital ECGs from the local ECG database, and this ECG data was thereafter analyzed through Advanced-ECG techniques using a semi-automatic software developed in-house. And this was done in order to determine the advanced electrocardiographic score for left ventricular systolic dysfunction. And now we have reached the results. And this is a busy slide that shows the baseline data of our cohort and the baseline characteristics that differed between patients with a high and the low advanced electrocardiographic left ventricular systolic dysfunction score. And in summary, patients with a score above 0.5 were generally older and of black race. They also had a higher proportion of comorbidity of hypertension, heart failure, and left heart catheterization. They also had a higher percentage of use of beta blockers, ACE inhibitors, loop diuretics, and insulin. They also generally had lower renal function and lower hematocrit, and lower ejection fraction and higher extracellular volume fraction. And in addition to this, they had a higher proportion of cardiovascular magnetic resonance examinations being performed on the indication of pericardial disease, arrhythmia, palpitation, and cardiomyopathy. Yes. And this table shows the prognostic value of the listed covariates. And over a median follow-up time of 4 years, there were in total 40 events of hospitalization for heart failure or all-cause death, and significant associations with prognosis were found for the Advanced Electrocardiographic left ventricular systolic dysfunction score, the extracellular volume fraction, ejection fraction, and left ventricular mass index. No significant association was found for the body mass index. And this slide shows the head-to-head comparison of the prognostic value of the respective measures. And the three top comparisons show that the Advanced Electrocardiographic left ventricular systolic dysfunction score significantly predict outcome when adjusting for extracellular volume fraction and left ventricular mass index, but not for ejection fraction. And they also show that extracellular volume fraction, ejection fraction, and left ventricular mass index do not significantly predict outcome when adjusting for the score. And the fourth comparison shows that extracellular volume fraction and ejection fraction both significantly predict outcome when controlling for one another. And the fifth comparison shows that extracellular volume fraction and left ventricular mass index also significantly can predict outcome when adjusting for one another. And the final bottom one shows that ejection fraction and left ventricular mass index do not significantly predict outcome when controlling for one another. And this slide shows the prognostic value of the components of the Advanced Electrocardiographic left ventricular systolic dysfunction score. And as you can see, only the Z-lead QRS integral was prognostic. And here's a table showing the contributions of these independent variables to the Advanced Electrocardiographic left ventricular systolic dysfunction score. And as you can see by looking at the global R-square, only 23% of the score can be explained by extracellular volume fraction, ejection fraction, age, milliander, and left ventricular mass index. And hypertension and diabetes did not contribute significantly towards the score. So now we reach the conclusions. So in a population without focal myocardial scar or severe coronary artery disease, left ventricular mass index, extracellular volume fraction, and ejection fraction by cardiovascular magnetic resonance, and left ventricular electrical remodeling by ECG are associated with hospitalization for heart failure and all-cause death. And the Advanced Electrocardiographic score for left ventricular systolic dysfunction showed the greatest contribution to adverse outcomes and incremental prognostic value beyond extracellular volume fraction and left ventricular mass index. And in addition to this, an increased advanced electrocardiographic score for left ventricular systolic dysfunction was associated with high left ventricular mass index, high extracellular volume fraction, low ejection fraction, female gender, and old age. However, these 5 parameters can only explain less than a quarter of the advanced electrocardiographic left ventricular systolic dysfunction score. And this suggests that the ECG detects prognostically important pathophysiological mechanisms of left ventricular electrical remodeling other than those which can be explained and identified by cardiovascular magnetic resonance. Thank you for your attention.
Well, questions and comments from the audience? John?
Did I understand? You passed over it very quickly, but
Sorry.
of the score, it was basically the amplitude of the Z lead that was doing the trick, right?
It was a C lead that was the only prognostic one of all the components. However, the score itself, and the score incorporates all of the 5 components, had the strongest association with prognosis. So even if they are not prognostic themselves singularly, together they contribute towards the score and give power towards the score.
Connecting with this answer, I will say, what happens if from this score you just take the one that is significant by themselves, the area under the C lead? Does it change significantly?
I don't think I quite understood.
Yeah, you replied to John saying that you take the 5 components, but you show that only one is significant.
Yes.
And my question is, what happened to the general score if you only take that one and you take out the other 4?
No, you don't take out the other 4.
I know.
Yeah, you use all those 4. But so one is prognostic, like as a singular parameter. But if you incorporate the results of all the other 5 into the score, then the score has a strong association with prognosis. But sorry, what was your question about something else?
Yeah, in a way, my problem is to understand why this is happening. Why, in an isolated way, those components show nothing, and when they aggregate, they show something. That's difficult to me to figure out. But
statistically, it can happen. If you look at pattern recognition statistics, you can get contributions from individual parameters in a logistics score that amplify the predicted value, even though they're not individual.
Yeah, but still will be nice to repeat the study, taking out those 4, just with the only one, to see how much degrade the total score.
Louise, you've done that, right? I mean, so if you look at just the C integral individually, what was its chi-square, for example?
Okay,
we had that, right? Compared to
we
the
can
score.
go back to...
5.6, and what's the score itself?
Its score itself, let's see.
7.5, so there's the difference.
Yeah.
I think that was your question.
Yeah, that was a question.
Yeah.
That was a question. More comments?
I would like to have an explanation.
Yes.
Why does it work? And now I understand more of your remark yesterday, because you are going to switch for definite from MRI to ECG. Is that possible? But, sorry.
We're making converts as we go.
Yes. An explanation of the components of the score, or?
No, I mean, why should an electrical phenomenon overrule the other predictors? Because I thought the MRI analysis was quite powerful. And I thought also that the MRI analysis explained much of the failure of the ECG to diagnose, for instance, left ventricular hypertrophy. Because journal Electrocardiography currently refuses papers about ECG estimates of left ventricular hypertrophy, because I think it has been decided in the past, possibly by Galen, this is bullshit. So now you come with a surprise, and I would like to know, can you explain why it works?
Okay, the answer is I don't know, but if you would allow me to speculate, I don't think, as people have discussed in previous articles, the ECG and CMR, cardiovascular magnetic resonance, they measure different things, electricity and structure and function. And so they should be used complementary and not in a comparative way. So patients that have undergone a cardiovascular magnetic resonance examination, and there's no pathology, which were the case of our study, our student study population, it would be prognostically important for them to undergo an ECG, because you might be able to detect electrical phenomena that might influence their.
But that's the clinical, let's say, the clinical consequence. You could also say, why not analyze every ECG that you see without, even without patients that haven't been referred to cardiac MRI, and see whether they have an elevated score. But the explanation, why does it predict so well?
why it predicts better than in this study better than.
Yeah.
As I said, I don't know.
Can we help?
But,
Or
yeah.
are we allowed to help?
Yeah.
Well, first of all, sudden cardiac death is an inherently electrical phenomenon. If you're going to look for an electrical phenomenon, you should use an electrical test. That would seem rather intuitive, rather than a mechanical test like ejection fraction, or an extracellular volume, which is again an anatomical phenomenon. So that in the realm of SCD, I think it's rather apparent. In the realm of pump failure death, all-cause mortality, it's not as a priori obvious. So, but clearly, left ventricular hypertrophy, we need to change the definition, the ECG definition. And that's why we're trying to move the direction of the community into a new term, left ventricular electrical remodeling, because it's not necessarily hypertrophy you're seeing. You can have LVH anatomically and a completely normal ECG, or vice versa.
If I may add in, when we look at ECG, we often can find all kinds of pathologies. But then we know that those pathologies are bad for you. We know that it's bad to have had an infarction, to have severe valvular disease, and all these we almost was an extensive list of exclusions. But that was the point, to look at the ones that are otherwise being deemed normal, which is a third of a CMR clinical population. And there, we should be not forgetting that there's a unique electrical information there that's giving us prognostic power. And that's what gets me excited about it.
Yeah, I would like to make a comment because does anybody except you is that left ventricular index?
The score?
Yeah.
Well, it's published in 2 different papers.
But
It's
independent
out.
The score?
Yeah. But I mean, so and it's all public domain. There's no reason anybody else.
No,
can't
no.
do it. Yeah.
I'm doing it.
You're doing it.
I'm doing it, but I have different input. I also calculate that integrals, but have differently.
Yeah.
And we did study, you forgot. A year ago, there was a study still waiting for some additional patients, and this is stem cell therapy in heart failure, in those candidates also for heart transplant, but this is non-ischemic origin. And if you're not familiar with stem cell therapy, is that it is stem cells are get from the from patient and are injected endocardially to some sites. What has been done is patients were followed before, immediately after, 3 months, 6 months, 1 year. And we have ejection fraction, we have a lot of data, magnetic resonance, we have ejection fractions. And what I did, I calculated in those that respond with increased ejection fraction to the therapy, also responded to that increase, to the score, and the correlation was 0.6 something. We are looking for, and I would say that there are so many different parts, components. For instance, there is also depolarization, because one of indexes is it dipolar or non-dipolar?
Yeah, there's a QRS non-dipolar.
It is something that's synchrony.
Yeah.
Yeah. Okay. So I think that there is something in this index score.
Yeah, and it's also the most reproducible score we have, and we can get it from the 10-second ECG, which is what's nice about it.
Okay, so some more questions? If not, thank you very much. And according to the agenda,
There's one more question.
sorry. Who has the question?
No, you do.
Thanks a lot. So you can reply even without making the question. The contribution.
Okay,
What is the
yeah.
contribution?
Okay, so I participated in the study design and in the MRI data analysis, and I performed all the inclusion and exclusion screening, and I coordinated the ECG data transfer from Pittsburgh to Dr. Slagle, who did the actual analyzing in Switzerland. And I participated in the statistical analysis. And yeah, and I wrote that.
Well, thanks a lot for pointing to that. And according to the agenda, well, so according to the agenda, we have lunch. But following Michael Bright's suggestion, we check if it's possible to delay lunch for half an hour, since there only remains one presentation in this session, and Vito nicely managed to postpone that, and I hope you are not so disappointed if we continue for half an hour more. And if that is the case,